Well, thank you very much. Thanks, Dr. Abdullah, for the kind introduction, and thank you, Ashwag, for the invitation. All right, okay. So I'm supposed to talk about the locoregional treatment. Dr. Ismail has already talked about the what is the point? Oh, okay. Okay. So Dr. Ismail has already talked about this, and Dr. Shwag have already talked about this. So my task is to talk about the locoregional treatment of HCC. And Dr. Bazarbashi is gone because I was going to point about the registry of the, the tumor registry. The figures that have been given out. Dr. Jum'a have talked about it, and Dr. Ismail has already talked it. So I think the tumor registry clearly underestimates the incidence of HCC in Saudi Arabia, because now we are depending mainly on the internationally recognized non-invasive criteria for diagnosis of HCC in patients with the cirrhosis. So we rarely do biopsies for patients with HCC. So I think maybe we'll talk about the tumor registry and figures in the tumor registry, and just saying, as I agree with Dr. Juma, maybe Dr. Ismail, that the tumor registry has clearly underestimates the incidence. So we may have to talk about how can we improve that and make it reflect the actual amount. So as I said, so most of the treatment of the HCC is mainly by the locoregional. As we said, Dr. Ismail has already mentioned this. The surgical treatment is only applicable to about 15 to 20% of patients with HCC, whether because it's bilobar disease or locally unsuitable for surgery, comorbidities, and again, the scarcity of organ in terms of for the liver transplant. So the aim of any locoregional treatment you apply is you have to have an objective, and the objective is to really to improve survival and also at least maintain the quality of life. Don't make it worse. And again, and this is for the definitive treatment if you're using it as a definitive treatment, and if you're using it for either downstaging for more curative disease like resection or transplant, or even bridging for transplant. So the locoregional treatments we have available, either the local percutaneous ablations, the transarterial chemoembolization, transarterial radioembolization, and planned embolization. Planned embolization is really rarely used, so I'm not going to talk about it. Or combination of any, and also the radiation, external beam radiation therapy, if you want to compare, include it as one of the locoregional. I think Dr. Shehri is going to talk about it, after that. Okay, so here what we have here for the locoregional, for the locoregional, the chemoembolization, and this is where, the EASL practice guidelines. So this is the grade of recommendation and the level of evidence, and you can see here the chemoembolization and radiofrequency or thermal ablation in general is about here, while the CERT or the TER, the radioembolization is here just because of the absence of randomized controlled trials. So over the years, the survival of patients with HCC have significantly improved from 16 months, as a natural history, then in the early 2000s, 20 months, and now it's about 40 months. The survival, and basically mainly due to improved patient selections. And also, getting a patient earlier, as well as the refinement of the technique, and also introduction of new treating modalities. So the basic requirement for tumors, of course, it has to be a multidisciplinary, a tumor board, and then it's as mentioned, patient selection is so important, and then again, the local expertise and the resources are important as well whenever you treat HCC. So in terms of patient selection, I mean, hepatic function, I mean, is very important, and that's just, I mean, really for safety, and patient in general condition, again, safety, and then the tumor-related factors, which is, I mean, the size, it's again, I mean, the efficacy, and a number of efficacy and safety, and the local and location of the tumor for the sake of, I mean, safety, efficacy, and visibility. I mean, sometimes we may be able, I mean, the tumor is in terms of size is suitable, and in terms of, I mean, the location is, but it's very difficult to reach. So that's not possible. All right. So in terms of the thermal ablations and or the local ablations, we have the thermal, which is, I mean, the radiofrequency ablation. Microwave are the most widely available, or I mean, used. Laser, HIFU, cryo, they are not much used. I mean, the chemical, alcohol, acetic acid, in the early, probably in the 90s and 2000, alcohol has been used. Now it's very rarely used. And then you have the irreversible electroporation, which has sort of been introduced in the past few years, but it still hasn't gained really much popularity because I mean, really it's just because of the complex application. It really implies sort of a low energy alternating current, where it doesn't cause thermal ablation, but it does cause the irreversible damage to the cell wall. So but it needs really, I mean, general anesthesia. It has introduction of multiple needles. It needs cardiac gating, because you have to apply the gate in the relaxation heart of the ECG. So it is a complex. So that's where we are for the local ablation, I mean, which is, I mean, microwave radiofrequency, and this is the more really updated, or the more advanced, where you see here the ablation for the very early stage, and for tumors less than 2, it's usually, I mean, the ablation is now the first line of and not resection. And then also the local ablation also can be used as well in patients who in the early stage, if they are not candidate, and they are not candidate for either resection or transplantation, or you can use it for a bridging. So in terms of technology, the radiofrequency ablation, it requires, a radiofrequency generator, electrodes on a grounding pad, where usually they have the high pads. For unipolar, there is a bipolar, where you have to introduce 2 needles into a tumor, and in that case you don't need the high pads. And they create a closed loop circuit alternating. It results in agitation of ions, and then finally it results in heat, and then coagulative process and cell death. So tissue destruction, it needs, 50 to 100 degree centigrade for about 4 to 5 minutes. And usually the guidance, whether it's mostly ultrasound, can be also done under CT or MRI, but you have to have, MRI compatible needles. The microwave, again, it requires a generator, antenna. There is no need for grounding pads. It delivers a high frequency electromagnetic field, and it results in, again, in a thermal ablation. And again, the guidance is exactly the same. So there are no randomized controlled trial comparing the microwave with radiofrequency. However, there are some retrospective studies which shows more or less similar outcome, and except that it has been claimed that you can apply the microwave for a larger tumor, and if you happen to believe in what we call the heat sink effect for microwave, then this is less susceptible. And however, the other point, and it has been noticed, the patients with after microwave, they are more prone for vascular thrombosis, like hepatic vein or portal vein thrombosis was that. and both are applied for the same stage of the disease. The outcome is more or less the same, and also the complications are more or less the same. So what we have, as currently as clinical evidence, it's more effective than the other local ablative therapy, and if less than 2.5 centimeter can be used as alternative to resection, and this is as incorporated in the ASLD guidelines in 2017, and if less than 5 centimeters can be suitable as if the resection is not possible, and can be used as a safe bridging therapy for transplantation, for patient waiting for transplantation. So the indication general is tumor single than single and less than 2 centimeters can be used as a first line for non-surgical candidate for tumors from 3 to 5 centimeters, and you can use it for tumor not more than 3 centimeters, just because you have to bring patients and back and forth for ablations, and then you may apply more modalities that treat all the tumors together. And of course, there should be no vascular thrombosis, no extrahepatic spread, and the liver function should be child A or B. As an example, and this is a perfect example of a tumor about 2.5 centimeters, and this is 1 month post. You see that totally necrotic. There is usually you see a rim enhancement, which is okay. That's not local as long as it's doesn't look like nodular. Then that's basically okay. And in terms of microwave, because of this lesion was relatively large, it's about 4 centimeters, so we elected to go for microwave. And microwave usually takes less time because it applies higher temperature than radiofrequency, and this is the outcome. About 4 weeks later, you see totally necrotic tumor. However, not all patients can be used. So for example, this is the patient I showed, which is an ideal candidate for radiofrequency or microwave. However, when you have, how can I play this video? Do I have to? I need to play. This is a video here. Oh, hey, okay, I'll do it from here. Can I play it? Okay, so when you see multiple tumors, so you know that, that you better probably select another criteria. You see there are multiple tumors here and there. So in that case, then the thermal ablation, microwave, or radiofrequency are not the best really modality to use in this. Or if you have a tumor like this, it's about 7 centimeters in size, then you better go for another modality to be able to achieve an outcome, a favorable outcome. Or if you have a tumor like this located at the hilum of the liver, so if you imply that there is a high risk of developing biliary strictures, and then you will treat the tumor, and you will end up with biliary dilatation, and you get the patient into different really problems. So in those cases, then you have to switch for the LOCOREGIONAL treatment, the transarterial treatment, and so TACE is for usually the first line treatment as per the BCLC guidelines for the intermediate stage. And the historical perspective. So the concept of hepatic arterial embolization was started really in the 1950s. With the concept that the tumor drives about 90% of its blood supply from the artery, while the rest of the liver or the normal liver tissue is venous. And the aim of embolization is to get the arterial blockage. And you cut the blood supply to the tumor and then end up with necrosis, of course. And the 40 micron size particles result in a blockade of the tumor and new vascular tissue. And this is here what we meant, that because the tumor supply is mainly arterial, so when you inject something in the artery, particles in the artery, whether it's radioembolization or chemoembolization, then you end up, most of it will be going to the tumor just because of the preferential arterial supply to the tumor. And in the 1970, the first case was performed by Hamad, and in the 1980s, improvement of drug delivery by using the Bead. However, in the 1990s, the selective test was developed. However, the initial randomized control trial showed the negative results in terms of survival benefit. Then those studies were really criticized because of the methodology. Then this paved the way for additional trials to be done. So in the 2002, two randomized trials and meta-analysis demonstrated survival benefit of TACE over the conservative or symptomatic treatment. And this is one of them by law, again showing significant the survival benefit compared with the control. The 3 years, or whether it's 1 year, 2 years, or 3 years compared with the control or the symptomatic treatment. And the other study by Levitt exactly showed similar findings. Again, if you compare the control with the TACE, this is just a bland embolization, and then again there is quite significant difference in terms of survival. And there are multiple other studies looking at whether to the survival or here the safety, and also for the downstaging role of the TACE. So currently the conventional TACE, the drug and gel form embolization that was introduced in the 70s is as infusion of mixture of chemotherapeutic agent with or without iodized oil or Bead, and followed by gel form or embolizing agent. So the idea here is to, when you embolize following the injection of the chemotherapeutic agents, to prevent washout of the drug from the tumor, and also to induce tumor ischemia as well. So, however, driven from the idea that probably in response probably does translate to better survival, so continuous improvement on the modality have sort of resulted in the introduction of the DC beads. So because it reduced the systemic passage of chemotherapy, because you lower the DC beads or the bead. There are here we're saying DC beads, but there are multiple other the drug eluting beads. So you load the chemotherapeutic agent on the beads and inject them together. So the idea here you have better retention of the chemotherapeutic agent within the tumor, and then you have slow release of the tumor of the chemotherapeutic agent into the systemic blood over time. And this has been shown by the studies I'm going to show. So the drug-eluting beads is chemoembolization with non-degradable beads. You load the beads with a chemotherapeutic agent, and so once it is within the tumor, then it releases the tumor over the chemotherapeutic agent over time. And this is the study done by the Barcelona group, showing here comparing the blood level of the chemotherapeutic agent going with the conventional beads, TACE, compared with the DC beads. Here you see there, within 5 minutes, you have, the level of the chemotherapeutic agent in the systemic blood is quite high, while here using the drug-eluting beads really takes time and it's quite low, and so that just, they indicate that it is retained with the tumor, so we have better, really, effectiveness of the And so DC beads have shown by different study that it is, I mean, at least, I mean, there is no survival benefit, but it is much more tolerated. And then this can be done also as an outpatient. So again, you reduce the cost as well. King Faisal experience. So we started here the drug-eluting beads service in 2013, and up to 2017 we have done 162 procedure on 111 patients, 111 patients with the mean age of 65. So we review the records of 108 patients with the mean follow-up of 15 months. And here the survival, the median survival was 31 months, which is really similar to what have been recorded reported in the literature. And here comparing the King Faisal experience with the other studies with conventional TACE. And here you can see more or less similar outcome, the 3-year survival and also the mean survival with other studies. Dr. Swail has talked about, I mean, the downstaging and bridging, and here there were about 9 patients that we used this modality for downstaging and the bridging, and the pathology, the RAD-BATH correlation was reviewed in 6 patients, was available in 6 patients. The other 3 patients were transplanted outside, so we could not get their pathology. So there were about, I mean, 3 patients, 3 out of 6 that showed complete necrosis, and 1 showed 70% necrosis, and the other 2 showed no response, and 1 with vascular invasion. So currently what we use as an indication for the chemoembolization is in the very early stage, if not suitable for more curative treatment, like, I mean, the thermal ablation or surgery, or large multinodular hepatocellular carcinoma with the preserved liver function and absence of related tumor-related symptoms. As an example of the here patient with multiple tumors, and this is a pre-treatment where you see multiple tumors, and this is 1 month post-tumor. You see complete necrosis, exactly the same. The 2 tumors showed complete necrosis. The same patient, another tumor, because it had multiple tumors, and showed complete necrosis. However, because of the unique things about, I mean, the hepatocellular carcinoma, there are 2 competing really risk of death in those patients, which is the tumor and the liver cirrhosis. So you may be able to treat the tumor, but then you have the risk of really decompensation. That's why the patient selection is quite important. This patient has a single tumor. Because of its location, it was elected to go for TACE, treated, and this is a cone beam CT that we do during the embolization, and you see the concentration or retention of the beads. This is without contrast. You see the retention of beads within the tumor, and this is 1 month later. You see complete necrosis of the tumor. However, there is, I mean, large ascites, and the patient started to decompensating. So the guidelines for the transarterial treatment. Here is the quality of the evidence for TACE. It's quite moderate, and for the radioembolization and embolization quite low, with the strength of recommendation for the chemoembolization was quite high for the intermediate stage. For the transarterial, how much time do we have?
4 minutes more.
It's okay. I'll try to conclude as much as I can. Okay. So for the transarterial or radioembolization, and really the radioembolization is not really the appropriate name. It should be really called probably the selective internal radiation, because we really were not embolizing. We're just injecting beads, which does not. I mean, if you do angio before and after, you'll see the vessels are still patent. So particularly because there are 2 types of radioembolization, or 2 manufacturers. One is the glass one, and there is also the resin one. The resin one are a little larger size particle, or not relatively, the size is not much different, maybe a little bit larger than the glass ones, but however, you have to inject a much more number of particles to the tumor to deliver the same dose. So you get the selective internal radiation particle lodge in the tumor vessels, and so it uses, yttrium 90 as beta emitter, and it gives high dose of radiation to the tumor and applicable to intermediate stage of BCLC, intermediate stage. And this is the difference between chemoembolization and radioembolization. For the chemoembolization, you really get embolization, so you cut off the blood supply. While for radioembolization, you don't cut the blood supply. You really inject the beads into the tumor, and there is it really kills the tumor by radiation. While here, it kills the tumor mainly by ischemia, in addition to probably the chemotherapeutic agents, and there is some debates about this. Is it really just ischemia or both? And one of the earlier studies done, they were by the Dr. Salim group that compared conventional TACE with radioembolization, and showed similar survival. However, it has the radioembolization showed a bit longer time to progression and less toxic than chemoembolization. And they confirmed this by randomized control study, although the number were so small because of difficulty in recruiting patients to the TACE arm. At King Faisal, the service was introduced 2008, and you will probably you'll see that we introduced it much earlier than the chemoembolization, and just basically because of at that time it was not available, the drug-eluting beads. Earlier on, and for the chemoembolization, you have to admit patients, and that will be probably was next to the impossible. So anyway, between the 2008 and about December, probably more than 250 patients we have done, and we reviewed the records of the first 88 patients, and there were about 199 procedures, so probably one procedure per patient, because some patients you have to bring for another back for an additional procedure. And the mean age was 63, portal vein thrombosis in 9 patients, and this is one of the differences between the chemoembolization and radioembolization. For chemoembolization, the portal vein thrombosis is considered to be as a contraindication, while not for the radioembolization. And follow-up, the mean follow-up was 16 months. And the results were quite really impressive, with the median survival was about 30 months for patients without portal vein and with portal vein thrombosis, or together. However, when we go for the subgroup of patients with portal vein thrombosis only, that the median survival goes down way to 11 months. And this is the survival curve. And so in terms of the downstaging and transplant and bridging, so there were 11 patients that were transplanted, and the histology was available for 8 patients, and there were no significant necrosis in 2, 25 to 50% necrosis in 2, and complete necrosis in 2 and 1. So where does the radioembolization fit in? It's probably going to be here. And it's not there just because still we don't have randomized control trial comparing it to TACE. And Dr. Riyadh talked about SERA trial for patients with advanced disease, as Dr. Aliya mentioned, did not show any survival benefit. However, it is less toxic than the sorafenib for patients. So the indication we use are here, and they just show one or two examples of that, and I'm probably just need probably 2 more minutes and I'll be done. Okay, so this is one example with one patient, an 82-year-old male patient with 2 tumors, and this is 1 month both radioembolization, where you see complete necrosis of the tumor. About 11 months. Doesn't show, and this is about 29 months or 30 months. You see the other thing that you will probably notice with radioembolization, you see that the right lobe has completely become atrophic with the hypertrophy of the contralateral lobe. And the other tumor, again, that's about 4 months, 10 months, and about 15 months or 19 months. Okay, and again you see that the tumor is completely necrotic with the atrophy and hypertrophy of the left lobe. And does that, however, translate to better survival? And this is what, this probably paper is not out yet, but it will be coming out, probably out in this month by, again, the Northwestern group, that after looking back into their experience, reviewing all patients that they have done and comparing responders, do they have better survival, by using EASL criteria for response evaluation, and the results was positive as well. So response does really translate into the better survival. Another example of portal vein thrombosis, a patient with portal vein thrombosis, tumor portal vein thrombosis with the tumor in segment 5, and this is 4 weeks, it's 3 months post radioembolization. You see that the shrinkage of the tumor and recanalization, partial recanalization of the tumor, and this is about I don't know how many months, but it's about 15 months or so, as you see complete recanalization of the portal vein post. So in summary, comparing the DIB TACE to conventional TACE, the DIB TACE has higher rate of response, but it did not show so far as survival benefits. And we're comparing radioembolization with chemoembolization. It has, again, there is no survival benefit, but it's less toxic and better for downstaging. When it's going to be, really included in the BCLC polystaging system. And here's this again by the Northwestern group, and again this paper is probably going to be out in this month or so, and they have adopted the radioembolization as first-line treatment for patients in the and not chemoembolization in the intermediate stage of liver of HCC, and that was based on review of about more than 1,000 patients over 15 years experience. And so, what protocol we apply here? At King Faisal, usually, the tumor board for the locoregional tumor, if the tumor is less than 3 centimeters and suitable location is usually RFA, provided they are not surgical candidate. And if the tumor is 3 to 4, we'll go for microwave. And if the tumor is more than 4 centimeters, we'll go for LOCOREGIONAL with our TACE or radioembolization. In some centers, for a tumor of 3 to 5 centimeters, they combine TACE with microwave or radioembolization. And that's it. Thank you.